for Wednesday, January 24th. I will remind folks that we are recording this meeting. You will see on the Teams an announcement of the recording. For record-keeping purposes and to help with the minutes, I'll just remind everyone, if you could please announce yourself before you speak with your name. And when you aren't speaking, if you could go on mute so we can avoid any background noise or distractions, that would be most helpful. So with that, our first item of business today, which is very exciting, is an introduction of our brand new board member, Christopher Moran, who comes to us as an appointee from Senator Duff. Christopher is an attorney for the state of Connecticut. He is replacing the seat that had been occupied by Elizabeth Keys. Folks will recall that Elizabeth had to resign due to accepting a job at the Department of Motor Vehicles. So there was no longer a very clear nexus between that work and this good work. And now we're grateful to have Christopher fill her shoes and be the board appointee of Senator Duff. So Christopher, I'll just let you say a word or two. This is a really terrific body that's engaged with vigor since we've been reconstituted. So I think you'll find it a worthwhile use of your time.
Hi, everyone. Thanks, Claudio. I'm excited to be here and help the board with all the important work that you're doing. So I'm really excited to be here, and I'm thankful to Senator Duff for this opportunity. So thank you very much.
Great. Thank you. And now I'll ask Melissa to formally call the roll for attendance.
Sure. So Claudio Gualteri.
Here.
Suchitra Krishan Sarin.
Here.
Deputy Commissioner Jody Terranova.
Here.
Aisha Clark. Ann Foley.
I'm here.
Tony Harp.
Here.
Parisa Charmchi Goodwin.
I'm here on my cell.
Thank you. Matthew Jasinski. Andrew Solner.
Here.
Christopher Moran.
Here.
Robert Boris.
Here.
Trisha Orozco.
Here.
Michael Rell.
Here.
Representative Cindy Harrison.
Here.
Thank you. Okay, Claudia, we're all set.
Great, thank you. So just to reiterate some of the goals of today's meeting, in October and November, the board expressed an interest in learning a lot more about the statewide activities concerning surveillance and tobacco prevention and cessation. I think that was well taken advice, that we look holistically and make sure that we're supplementing and coordinating with those existing resources and initiatives. We also heard that DEMIS would be a core partner for us in helping to understand what's happening at the local level and through their initiatives. And obviously there was some interest in the board of making sure that when we put forward our allocation plan, that it is synergistic with the Juul settlement. So we're pleased that DEMIS staff is here today to provide us a presentation. They're going to spend some time talking through the work that they've done, their local behavioral health organizations, and some of the survey findings that they have at the local level, and how those are in concert with what we're trying to do at the Tobacco and Health Trust Fund. We also have someone who will be able to give us a quick update on the Juul settlement. The next part of our agenda will be really dedicated to reviewing and walking through the written allocation plan that we would eventually send over to the committees of cognizance, hopefully in early February. I understand that you guys got this late yesterday and had maybe not had a chance to fully review and read the plan. Recognizing that, we're going to actually take time where Melissa can walk individuals through. We'll take questions. And if after review we feel that it would be merited to have a little bit more time, we will hold any vote or further action on the formal written plan and call a special meeting for the sole purpose of doing that. If, however, we feel that the plan is simply a formulation of what we'd had already voted on and discussed in our last meetings, and the board was comfortable moving forward, we could entertain such motion at that time. So with that, I will turn it over to Jennifer Sussman from Demas Center of Prevention, Evaluation, and Statistics at UConn Health. She's going to provide an overview of their regional prioritization reports. Jennifer?
Great. Thanks so much, Claudio, and very happy to be here. I will share this presentation. All right. So again, I'm very happy to be here. So I'm Jennifer Sussman, the coordinator of the Demas Center for Prevention, Evaluation, and Statistics at UConn Health. I'm a research associate in the Department of Public Health Sciences, and we serve it basically at the pleasure of the Demas Prevention and Health Promotion Unit. We are funded as a resource link to that unit to provide data and evaluation support to stakeholders, partners at the state, the regional, and local levels. As part of that, we have supported over the past decade or two a prioritization process that's occurred in various forms at the regional and sub-state level. So the Demas Regional Priority Report process actually has a few different purposes, and one is to meet the requirement of our federal substance use prevention, treatment, and recovery services and mental health block grant funding that requires that states on an annual basis assess a variety of constructs, needs, strengths, gaps, and identify target populations and priorities for those populations. So that's sort of the federal and the state reporting purpose that this partially fulfills. However, under the Demas PHP, Prevention and Health Promotion Unit, there's strategic planning, needs assessment and strategic planning going on at a variety of different levels. And as strategic community partners, the regional behavioral health action organizations, which are the planning entities that have been funded and charged by the Demas PHP, to assess the needs specifically for children, adolescents, and adults, but with different focuses for different initiatives, but and then to develop regional strategic plans. And I'll talk a little bit about what those plans include. And, part of the relevance to this group is these recommendations and these elements that come out of these plans span prevention, treatment, recovery across alcohol, tobacco, and other drugs. There's mental health, suicide, problem gambling components as well. And as the Demas PHP's resource link around data and evaluation, we support this regional strategic planning process through the development of guidance documents, the provision of data, and report formats and tools for the regional behavioral health action organizations to use to do this work. These are the regional behavioral health action organizations. This process stems from a time when there were actually 14 regional action councils on the alcohol, tobacco, and other drug side, and regional mental health boards on the mental health side. And over time, they've sort of coalesced and been refunded as 5 behavioral health planning regions. And so when you see us refer to region 1 through 5, these correspond to different areas of the state. And they're all represented by organizations that are also listed here. The regional process has several components. It centers around a regional behavioral health priority setting work group. We call it the work group. That's identified by each of the regional behavioral health action organizations. Includes stakeholders. It includes, in some cases, government officials, treatment providers, consumers. It's a very multidisciplinary group that convenes to do this process. The process historically has spanned about 6 months, It includes qualitative data gathering, reviewing quantitative data, and a prioritization process, and then the report development process. So each of the regions has a little bit of a different process for doing this work, but certain elements remain standardized across RBHAOs. One thing to note is that we right now are retooling this process, and these kinds of presentations and feedback from organizations that could use this data will feed development of a more standardized survey instrument to do some of this work. We're looking at the report elements to standardize them to make reporting more efficient and ultimately more useful for organizations like yours. So that will be happening in the 2025 regional planning process. And I should mention that while the requirement for assessment is annual, the regional priority process is biennial. So the process just occurred in 2023. It will occur again in earnest in 2025, with updates occurring in the in-between years. So basically, this process involves, as I said, administering provider and stakeholder surveys, conducting focus groups, listening sessions, key informant interviews, and then reviewing and analyzing data, epidemiological data that I'll go into in a minute. Some of it is surveillance data that DEMIS uses, and some of it is data related more to consequence and social determinants of health and those sorts of things. As of now, the regions prepare epidemiological profiles for the regions by all of the major ATOD, substance-based issues, mental health issues, suicide, and problem gambling. Then they use that data that they've gathered in various forms to identify strengths, services, resource gaps, and needs. They use that information to conduct a prioritization process with this work group in each of the regions, where they select priority issues, substances to address at the regional level. And then they pull all of this into a comprehensive report, utilizing a specialized template. The strengths, services, resource gaps, and needs, and the report content feed into the block grant report that gets submitted by the state, but it also gets used at the regional level with stakeholders. So that's the step 10 here. That is really, in some ways, the most important aspect of this work for the RBHAOs. It's a very rigorous process as it stands. It's also a data-informed process, and the epidemiological data that gets used spans state, regional, and local data sources. What you'll see highlighted here are, the more surveillance-based sources that DEMIS also monitors over time, and that's relevant to, to tobacco, electronic nicotine delivery systems, all of the vaping and related issues. So that's the Connecticut School Health Survey, which is Connecticut's youth risk behavior surveillance system. So there's state data comparative to national data, and there's subgroup data, but there is not regional data. And then the same for the behavioral risk factor surveillance system survey, which is for adults, and the National Survey of Drug Use and Health, which is national and also provides DEMIS regional estimates as well. You can see that exists, amidst a variety of other data that the regions use: hospital and ED, syndromic surveillance data. This isn't data that's monitored at the state level with the same regularity right now or historically as these three Department of Public Health sources. We do work very closely with DPH to utilize the surveillance data that they develop and provide, and we'll be doing more with the hospital and ED data going forward. But you can see stakeholder surveys, community health needs assessments play into this, EMS data, treatment admissions data. Again, it's a very rigorous process that feeds into the epidemiological profiles and also into the prioritization. In addition, there's a lot of local qualitative data that's gathered, and the meat of the recommendations and priorities that you'll see here is based quite heavily on this kind of data, because this is the only data that kind of gets at stakeholder, provider concerns and needs at the most local level. So you can see, you know, they use their existing meetings to ask the kinds of questions that feed into this process. And I do have those questions not in this presentation that I can share with you that are required that they ask of stakeholders. There are also, in addition to that, there are these key informant interviews with state and governmental entity key informants, public health analysts, faith-based family members, et cetera. And you can see just the variety of stakeholder data collection that feeds into this process as well. So I popped the tobacco and health trust fund priorities in here so that we could just be mindful as we walk through these more generalized recommendations. You will see these priorities kind of come to play in these larger recommendations. And while the regional reports have not been mined specifically for tobacco and health trust fund priorities as such, that is definitely something that could happen over time. And we'll talk about that in a bit. Focusing on substance misuse priorities for the 2022-23 prioritization, you can see that tobacco and ENDS and electronic nicotine delivery systems break out separately. And as you can see, electronic nicotine delivery systems, while not a substance, really a delivery system, a mode of use, is driving concern across the regions. So, you know, heroin and fentanyl is and alcohol are at the top, but very, very closely shared in some regions. And where these colors are blurred, it means that it was essentially a tie between these two. So you can see in region 1 that ENDS and heroin, fentanyl, you know, we're kind of the top priority. In region 5, alcohol and ENDS, and alcohol and ENDS as a second priority in region 4. But the tobacco concern has remained low mostly because of the supplanting for youth, adolescents, and young adults of traditional tobacco use as kind of a transition into electronic nicotine delivery system and systems, and the high concern over vaping is driving a lot of this. So on average, heroin and fentanyl, alcohol, and electronic nicotine delivery systems were the top 3. So it was the top 3 in 4 out of 5 regions, followed by prescription drug misuse, marijuana, cannabis, which does figure into the vaping discussion, and then cocaine and tobacco. In terms of emerging issues, some of the things that came out of this process, for some of these, it's a matter of a substance or an issue that's emerging, and for some, it's really a population that's emerging as an area of concern. So, you know, in terms of illicit substance use driven by overdoses and those sort of thing, xylazine has been an area of concern. But you can also see Zinning, oral nicotine pouches, coming up as an area of concerns. It was brought up by region 1 and 2, but we've seen it across the regions. So Zinning specifically for youth and young adults. Caffeine pouches also came up, a similar product, but for a different purpose. And then cannabis, the concern has been specifically emerging for youth and young adults, decreased perception of harm. You can see right here the coalescence with ENDS vaping. So that's where, you know, dabbing and carts come in terms of use of cannabis and THC basically with ENDS and vaping. And then, you know, you can kind of see the way certain things are maybe a little bit more localized or a little bit more specific. Specifically for ENDS and vaping, Again, youth and young adults are really what's driving this concern, is sort of the emergence of that issue. The rise post-COVID has been identified as an issue, and then devices modified to increase nicotine as well as THC. And this is something that is, definitely relevant to this board. And then counterfeit pills and alcohol as well. In terms of underserved populations, we did take a look across substances and priorities. And there are no numeric representations here because this really is sort of, this is a, how do I want to say, it's a relative sense based on mentions, number of mentions, where it showed up in this process. So you can see that the LGBTQ plus population, veterans in the military, young adults, older adults, undocumented immigrants, and those with cultural language differences came up the highest in terms of underserved populations across areas of concern. In terms of resource gaps and needs, and again, these are across ATOD and to some extent mental health, suicide, and gambling as well. Thematically, funding and resources, human, staff, and financial came up highly identified in resource gaps and needs. And then sort of the cultural and basic service support needs came up very high as well. So, not surprisingly, given these populations of concern and undocumented immigrants, those with cultural and language differences, and lower socioeconomic status groups came up as well, that resources to address cultural barriers and barriers to treatment, like transportation, childcare, and other basic service supports, came up as resource gaps and needs. Again, you're seeing youth, adolescents, young adults come up in the need for behavioral health treatment for youth and adolescents and young adults, interdisciplinary approaches that integrate prevention and treatment across substances and co-occurring disorders. Again, is a need, is a resource gap in need across a variety of issues. Tobacco, vaping cessation programs specifically for youth and young adults came up as a more specific resource gap. And then education and awareness resources across ATOD, which you'll see a little bit more specifically later on. In-home family-based treatment options, expanded crisis response services, and recovery support, again, across substances. So you'll see the way these sort of play out in the slides to come. So alcohol, tobacco, and other drug prevention recommendations, which are driven partially from areas of concern and partially from identification of resource gaps and needs, involved, again, increases in funding support, not surprisingly, especially at the local level, the local prevention councils. And one of the reasons why this is particularly relevant is because local prevention councils are funded by DEMIS to address vaping and electronic nicotine delivery systems. And that's one of the key local efforts at the town level across as many towns as apply for this funding. So that's something that's particularly relevant and maybe an opportunity for data collection at the local level that might feed, some of the work that you're doing. Education and awareness building aligns with, one of your priorities. And there are some tobacco specific recommendations that I'll get to in a minute. But, targeting specifically parents and youth, an enhanced focus on co-occurring disorders, underlying causes, risk and protective factors, contextual factors, social determinants of health. And these apply to concerns that, every committee has within the state of Connecticut, regardless of, what the area of focus are. This really is sort of that more organic approach to connecting the risk factors and protective factors across these individual substances. Treatment recommendations focused on basically increases in resources and access. Tobacco cessation was one of these areas. Harm reduction and, kind of crisis sobering centers was another area. Increase in access. increase of resources obviously is connected to increase of access. But there's also the addition of the need for these community connections, these warm handoffs, these local, community-based supports that can get people to treatment and keep people in treatment. And then expansion of culturally informed and sensitive treatment. And some of that is through workforce development, some of it's through outreach, and again, these community linkages. And I realize I'm going through this all quickly, so if at the end, if we want to go back to any of these slides, more than happy to do so. Recovery recommendations also focus similarly to treatment recommendations on improvement of access across the populations. And, you can see some of the things here. I won't go through the whole list, but you can kind of see, how cultural competency and cultural representation and inclusivity feeds into these, how the continuum of care, post-treatment follow-up figures into these, and how these community-based recovery coaches, and, the focus on recovery in general at the community level is a recommendation. We did do kind of a quick scan of the recommendations to identify tobacco-specific recommendations. So in the areas of prevention, routine retail compliance checks, specifically to prevent sales to minors, social marketing and education around tobacco vaping ends, and then policy work to ban flavored vaping products, which some of that work has already been done, some of it's still in process. In the treatment realm, virtual cessation programs were recommendation in several regions. Youth and young adult cessation came up again and again as a gap and a need for strengthening. Culturally informed treatment for Black and Indigenous people of color and LGBTQ, as well as for women. And then under recovery cessation support for youth, young adults, again, you can see promotion, education, social marketing to promote the understanding of tobacco or vaping recovery support. One of the things that was found was there was a lack of recognition that you could recover from tobacco or vaping, that it was something that was from which recovery was actually needed. And then across all this, there are, of course, the state systems recommendations, which, again, I will not go into in detail. You have this presentation, you can look as these apply a little more specifically to particular substances or areas, but workforce development, the need to promote and support a culturally sensitive, inclusive workforce, including training in co-occurring disorders, and again, those underlying risk and protective factors, a fast track to certification, increased funding, and the implementation of innovative strategies to grow the workforce from MPH programs, from social work programs, from clinical training, to increase the diversity and quality of the workforce. Awareness education, again, was a sort of a systems recommendation. There were recommendations to educate policy leaders and treatment providers on harm reduction, develop a statewide education plan for youth, parents, and businesses to address underage drinking and DUI. This could easily be applied to other substances as well. Develop statewide awareness plans and campaigns. You can see nicotine use and ends as a delivery system came up as a specific area for this recommendation. And then educating primary care networks about the RBHAO vaping resources. So the resources that are available at the regional level. There needs to be awareness built that this is a resource, and that's something that Demas can talk about in more depth, and also the local prevention councils as a town level resource, and then recovery friendly workplace initiative, and then finally increasing training and education to providers on trauma, PTSD, and its relation to all of these other behavioral health issues. Finally, cultural competence and inclusion, and we've been over, the fact that this is central to pretty much all of the gaps and recommendations that have come up in this report. Again, increasing funding for culturally specific behavioral health centers, increasing participation of people with lived experience in all local and state level decision making, increasing cultural competence training of behavioral health providers, building capacity and readiness among underserved populations, and then applying non-stigmatizing language to all public-facing content. And that's something, again, that applies across substances and across issues. Finally, policy and advocacy was another thematic area for state systems recommendations. And you can see, reviewing policies and eligibility requirements for in-home treatment, telehealth, ways to increase access to treatment, advocacy for comprehensive field sobriety tests for cannabis, and then promoting and implementing recommendations of the ADPC Prevention Subcommittee Cannabis Work Group. The reason I highlight these policy advocacy recommendations is that they do dovetail with with the way tobacco concerns have shifted over to vaping and electronic nicotine delivery systems. There's no way to sort of address vaping and ends without also addressing cannabis. And that's one of the reasons why I highlight those here. Conclusions and next steps. While you saw that tobacco use via smoking and traditional means ranks low among the regional priorities, it's not a low priority to begin with, because those priorities are comparative and ranked. As other things rise to the top, other things necessarily move down the list. Anything on the list is still a priority in the state and still a priority for the regional behavioral health action organizations. But while tobacco has kind of moved down the list, ends and vaping is a high priority across regions. And, that's a way in to address the larger issues that this board and the work of this committee seeks to address. The DEMIS regional priority reports do contain content relative to your priorities, specifically including treatment prevention and recovery recommendations, stakeholder perspectives, emerging issues in at-risk populations, as you've seen, needs, gaps, and resources, and then these regional epidemiological profiles, which I have not gone into, but are available to you for tobacco, ends, and all of the other substances. For possible next steps, one of the things that I have to say is we really didn't do a deep dive into the regional contents through the lens of your priorities. Because this process is largely qualitative in nature, and the reports look slightly different by regions. One of the aspects of this process that we are retooling is to try and develop report elements that we can more easily mine for the kind of information that committees like yours are interested in. So possible next steps could include a deeper dive into the regional content through the lens of these priorities to inform recommendations and advocacy if that was desired. And then also monitoring of regional priority report findings that you find useful over time, because this is an ongoing process. The last thing I'd kind of like to say about this is that the DEMIS regional priority reports can be found via the link in this PowerPoint, and they're on the DEMIS website. That's where you can find them. And I would highly suggest reaching out at the regional level. There's a wealth of information here that I just didn't cover here because of time and resources. And so with that, I will thank you all for this very opportunity to do this quick overview, and open it up for questions if anybody has them.
Thank you, Jennifer. I think it was so helpful for you to sort of take and digest some of the findings at the regional behavioral health organizations and crosswalk them to our big priorities and categories. And it certainly feels like there's some synergy, and I appreciate the next steps you've identified to continue to bring in Demas's work and inform through the local community work what we do here in terms of resource decisions. One quick question is, as we approach the next phases, which obviously later today we talk about the allocation plan, eventually we will send that over to the legislature. It's anticipated that we would RFP out the competitive processes under each of the categories that DPH will lead. And I'm wondering if another next step could be inviting the regional behavioral health organizations as planning entities to maybe, provided they have no conflict of interest, to serve as technical assistants in helping to write those RFP proposals and or evaluating those, just to make sure that what we're getting as responses are lining up with what we're hearing in the community and identified gaps. So I'll put that out there as a potential opportunity for follow-up. And certainly we would hope that once we have the competitive process up at DPH, maybe the regional behavioral health organizations can also be a conduit for pushing the word out to their networks and to their communities of the funding opportunities that we're soliciting. So 2 additional thoughts that you can take back and follow up with us. I see that Dr. Salner has his hand up. So without ado, Andrew, go ahead.
Thanks, Claudia. I appreciate it. Jennifer, thanks so much for that excellent presentation. We really appreciate it. Is there data available concerning what the regional entities have now in terms of programs for their priorities, and in particular, the ones that we're concerned about, what the budgets are for those and what the outcomes of their programs might be in terms of success in dealing with the issue?
So that's a great question. And, what I will say is that the first thing I will say is that, with regard to the regional priority reports, there is information in the reports in each of the EPI profiles about resources within the region. That's not specific information. So that's the first thing I will say. And I think I might defer to Sarju for the Demas answer on, information on budgets, activities, and that, that kind of information. Honestly, I will say that I think we can always do a better job of monitoring outcomes at the regional level. And, part of retooling this process, has a little bit of an eye toward that, but I'm actually going to defer to Sarju to give the Demas answer on this.
I was very excited for you to keep going, Jen. That worked for me. Hello, everyone. Good morning. Oh, it's still morning. So for us, I am the director for the Prevention and Health Promotion Division within Demas, and my team oversees the RBHAO contracts. The way that our contracts are currently laid out is we really focus on primary prevention activities. We were able to dig in a little bit more if you're looking for specific information, and we're happy to provide that through Claudio if you'd like us to look into that a little bit more, to provide you some of that pieces of it. But our focus is really on primary prevention activities around substance use, as well as the alcohol, drugs, and other alcohol, tobacco, and other drugs pieces of it. And the funding that we have is primarily through our block grant, which is what Jennifer talked about earlier on, which is the that looks at really the substance use prevention, treatment, and recovery. And most of our programs are related to that pieces of it. Addition to that is that we at Demas also have the tobacco prevention and enforcement program. And what we do in layman's terms is we really do undercover buys for tobacco retailers across the state. We hold both the state, we work on the state side, looking at state policies and regulations, as well as we also hold the FDA contract and look at federal laws and regulations. With that piece of it, I can say, and Jennifer talked about it a little bit earlier on, is that looking at non-compliance of how many retailers are selling tobacco and end products in Connecticut, our rate is for 2023 was about 13% of those retailers being non-compliant. And what that means, and when we're looking at that data, what we saw, and those are retailers who are selling to those who are under 21. What we also identified through that is that, and Jennifer talked about it a little bit earlier on, is that we see that tobacco is not as high in prevalence of being purchased by those who are under 21. We really see that the increase in end products across the state. So we can provide a little bit more data in that sense if you'd like. I don't know if I answered your question, but.
Yeah, and the final thing I think I will say on a more qualitative level, right now, actually, we're engaged in a statewide prevention resource assessment. And so, you know, one of the pieces of that is to survey all the local prevention councils and all of the RBHAOs and compile that data into an interactive document and a filterable map. We're doing it across substances, so there will be tobacco information included in the report. And it's a first step. And the last time this was done, I think was, I want to say 1997, I think was the last time that this was done. So, you know, we'd be happy to talk about that when that work is complete.
Excellent. That's helpful. Suchitra.
Good morning, everyone. Suchitra Krishnan-Saran from Yale. Pleasure meeting you all. Thank you for that great talk, Jennifer. It was so comprehensive. Really appreciate it. So I guess my question was, when you are doing this, I had the similar question to what was raised earlier about what local resources are available in every region. So it would be really nice to see that, and also possibly more information on, you know, the priority table you put up, where you said that there was within regions, there was more interest in nicotine or ENDS products in some areas and not. Was that drawn based on qualitative data, or was that some of the BRFSS data or the YRBS data? Where did the prioritization come from?
Yeah, again, another great question. It's combinations. So there's a prioritization process that involves a review of epidemiological data that you can see, you know, in looking at the profiles and those data sources that I discussed. That gets presented to a work group, and they look at each issue through the lens of magnitude, you know, the magnitude of the problem, impact, severity, changeability. There are a variety of constructs that they apply to this and do a ranking process that involves all of these. That is based on presentation of the key stakeholder data, so that qualitative data collection, as well as epidemiological data. And then the reason why it's so important that the group be really, you know, span stakeholder groups, sectors, perspectives, is that it is a group ranking process. And so that table that we showed represents a numeric ranking process that does take into account that variety of, you know, some definitely more objective, quantitative, and some more subjective data. The value in it is that it's based on the people who are of and in the region. So it is a truly sort of local assessment of priorities.
I see. Thank you. And I had a question for Sarju too. Thank you for what you spoke about. So I think when you present any work to us on what the local, you know, what is available locally, you had discussed going in and kind of evaluating what the various vendors are carrying. It would be great to also know if the products that you evaluate contain nicotine or they contain cannabis, because this issue has come up, you know, as you know, over and over again. Most of the cannabis products, from my understanding, are available in very select locations and not necessarily in the general retail stores that sell general ENDS products. So I think that would be a good thing to know if you have that data. And the other thing I would also suggest that is, and I don't know if you collect this information, but there is a lot of the local vendors actually have contracts with tobacco industries and other vaping industries to highlight the presence of their products in front of the store, you know, put pictures on the windows. Is there any information? Do you have any data on that kind of information? Because those contracts also make a huge difference in terms of where the products are placed and how visible they are to a lot of the youth.
Sure. So to answer your first question, we have a staff of 9 investigators who go out into the communities across the state. And what they do is when they're doing those non-compliance checks or the compliance checks itself, they are identifying the different types of tobacco and nicotine and end products that are out there. We have, through our requirements, through our SUPTERS block grant, we look at tobacco products, single loosies or single cigarettes. We look at cigarillos and cigars. We look at end products. We also look at anything else that is out there right now. So loose leaf tobacco. Trying to think of the list at the moment. In addition to that, what we have also identified, we also collect, products that are purchased. So is it a Zyn? Is it, a Marlboro? Is, what product type it is? We also have identified many of even though the laws have changed in Connecticut and, no non-licensed dispensary is allowed to sell any type of THC product over 0.3%. We have identified quite a few of those throughout the state. And what we do is we do have a partnership with the Department of Consumer Protection as well as the Department of Revenue Services. When we identify these in these products that are not should not be sold in these tobacco retail, we work with those agencies to provide them that information so that they can do the enforcement pieces of it. And I'm happy to share the types of products out there. I did not bring that to this presentation, but I can showcase the type of materials that are out there, etc. We have quite a few of those pictures. As for the settlement related to and the big tobacco and the advertising pieces of it, we have worked with our Attorney General Heather, and I'm blanking on her last name, and I'm so sorry for that. But she's amazing. And what we have worked with is we looked at the tobacco-free campaign. We've identified all of the and on that website, it showcases and identifies all of the retailers in Connecticut who should have some type of sign up in their premise. And the number of signs that they're supposed to have, as well as if it should be in English and in Spanish. And what we do is this is not part of our project or the work that we do, but we are working with the AG's office to ensure that, when our investigators are out there, and if we've identified any of these retailers that are identified in that list that do not have this information, that we will be sharing that with the AG's office. I hope that helps.
Yes, it does. Thank you.
All right, there's Tricia.
Good morning, everyone. Just to piggyback on some of the great presentation that Jennifer, highlighted for us, very comprehensive. Thank you for that, a wealth of information. I wonder with this group considering school-based health centers, because throughout the regions, there's this, we're seeing ends and we're seeing vaping being a part of the youth and families. School-based health centers across the region have access and have partnered with the school district. So I'm wondering if there's additional ways that we can utilize school-based health centers as A, resources, and B, looking at opportunities to partner further with the school-based health centers across those regions to do some campaigning around vaping, around cessation programs and psychoed right there in the school-based health centers.
Yeah, that's a great point.
All right, any more questions? If not, I'll turn to Sarju, who's going to do the second part of the presentation, which is a brief overview of the Juul settlement that the board has been interested in learning a little bit about. And then I will note for the board that in my enthusiasm and excitement to get to our DEMIS presentations, I skipped over the minutes. So upon finishing this piece, we'll go back, do approval of the November minutes.
Thank you again. Again, pleasure to meet all of you. And I promise this will be a 5-minute presentation. It's not as thorough and amazing as Jennifer's, but that is why we have Jennifer as a part of our team. So just a quick overview. Hello again. My name is Sarju Shah. I am the Director for Prevention and Health Promotion Division within the Department of Mental Health and Addiction Services. And our division really oversees and administers the prevention set aside funding for the substance use prevention, treatment, and recovery block grant, as well as a SINAR amendment, which I talked about a little bit earlier, as well as other discretionary funding that supports our alcohol, tobacco, and other drugs purview. And you have my email address here. If you have any questions, you're welcome to contact me directly. And this is just a quick update on the Juul settlement. And there we go. So just quickly, you know, Juul Labs introduced e-cigarettes back in 2015. You know, they were a pioneer in the vaping industry and accounted for almost 75% of the e-cigarettes sold. In 2022, the FDA ordered them to stop selling vapes. Juul Labs then faced over 5,000 lawsuits, with most of the lawsuits stating that the company engaged in either deceptive marketing or failed to warn consumers about the risks. We were very fortunate to have Attorney General Tong and his team, who led a 2-year investigation and brokered about $440 million agreement in September of 2022 with 34 states and territories. From this settlement, Connecticut may receive $16.2 million over the course of 6 to 10 years. The map that you see here is from the Public Health Law Center, and the link of that, if you would like to play with the map a little bit more and learn about some of the other states, is underneath the map itself. They have created this interactive map where they are collecting settlement agreements for all the states and territories that are publicly disclosed, just as an FYI. And as you can see on the left-hand side, you can see that 33 states had the multi-state settlements back from September 22. In April of 2023, there were 7 multi-state settlement agreements that were announced, and then the blue ones were individual state settlements from 2021 to 2023. So just kind of gives you a high-level overview of that. And then the gray ones are states yet to settle. With that, what I wanted to just give a little overview, a high-level look at is Public Act 23-92. This is an act concerning the use of funds in the opioid and tobacco settlement funds, as well as funds received from the states as part of any settlement agreement with the manufacturer of electronic nicotine delivery system and vapor products. Starting in federal fiscal year 24, the Public Act requires that the amount of the Juul settlement funds that the state received in the prior fiscal year to be dispersed to DMAS, to then distribute the funds to the state's 5 regional behavioral health action organizations, or the RBHAOs, as you have seen from Jen's presentation. And that is really to support programs that support abatement, mitigation, cessation, and reduction or prevention of nicotine and nicotine synthetic products to those under the age of 21. These funds are to be expended by June 30th, 2024, and that report will be then submitted to this group by September of 2024. We received in late 2023, we did receive confirmation that we have received $1.5 million, and we are currently working to prepare contracts to the 5 RBHAOs with approximately $300,000 per contract. Due to the timing of everything, we do know that we will not be able to expend all $300,000 by June. We're hoping to extend that contract to really do more of a strategic planning piece of it and ensuring that the funding is going to be utilized in an appropriate manner that really support the regional activities, as well as the priorities that you saw in the prior reports. And as Jen mentioned earlier, our RBHAOs are really our strategic community partners, and we work really across the behavioral health continuum. So they're responsible not only for the behavioral health planning, they're responsible for education, mental health promotion, suicide response, prevention and response, as well as the substance use prevention, treatment, and recovery within their respective regions. They are community partners. They do work across many of the different sectors, and they have great relationships with not only their health departments, health districts, school-based health centers, or some of them, their other nonprofit and community organizations, and really focus on working together and building more collaborative relationships and focus on that. And that is my presentation. Very simple and quick. Questions for me?
That's great. Appreciate it. Any questions from our board members? Yes, Tony.
Hi, good morning, everybody. And I want to thank both speakers for their reports. I guess I'm wondering, since with this particular report, I'm just wondering if, since there was the thought that this would have been done earlier had the money been available, were there goals and objectives already? And had you already begun a planning process? And since obviously it wasn't finished because you're going to move into a planning process, what do you expect to be to come out of that process? Will there be goals and objectives by regional area? Will there be statewide goals and objectives? And if you could kind of just give us a sense of where that will get us to and what we'll have to look at once you finish that process.
So to be pragmatic of the funding that we have, and when we receive this, we do have to go through the contractual process. What our hope is that we utilize a strategic prevention framework, which is a public health model that really does an assessment. We are fortunate to have done quite a bit of that with the regional priority reports. And what we will do as part of this contract is identify both the regional goals and objectives of what we are able to do, and look at that over the course of the funding stream. So our goal would be to identify goals and objectives by region, as well as looking at it holistically over the state, and then model that after some of the priorities that you see for this group. Short answer. And I'm hoping by by September that we would be able to provide you that, as well as a baseline, some additional baseline data that would help support what we're looking to deter over the course of the next couple of years.
Okay, thank you.
Yes, Suchitra.
So very short question again, Sarju. How specific are these priorities going to be for tobacco nicotine? Or are they going to cover all the other general areas that you discussed, the dual settlement priorities?
The dual settlement is focused on vaping products, and that's what we will be focusing on. So we will, and as you can tell from Jen's presentation, each one has a little bit of a different regional flavor to it. So we want to ensure that we are impacting our regions of what is happening in their regions, and working with them to identify that and deter those pieces of it. So our goal really is to increase primary prevention, and especially specifically looking at how to deter youth from starting any use of these products, as well as really focusing on how to inform them and making informed decisions of their health.
Great. Seeing no further questions, I'll thank you for two really wonderful presentations, and I hope Demas will continue to be, and we'll do our part to make sure that you guys are informed, but please stay in contact with this work. I think that the board really wants us to be collaborating and bringing all the resources to bear in a fashion that is symbiotic. So thank you.
Thank you.
I will. Great. And now I will go back to the agenda item that I had neglected earlier, which is the approval of the November minutes as part of the package of materials for today's meeting that went out yesterday. Melissa included our November 13th meeting minutes. I hope folks have had a chance to review those, and I'd now entertain a motion to approve such minutes.
I'll move it, Claudio. It's Ann Foley.
Thank you. Motion has been moved. Seconded by Dr. Salner. All those in favor, please signal by saying aye. Oh, comments. Sorry. Yes. And for purposes of comments or edits.
Actually, it's just a process. It's not an amendment. And I did want to say that I think the minutes are consistently well done. They're comprehensive, and I think they're quite accurate. But it's been a while since our meeting, and I do think that they have to get posted after a short period of time on our website. And I wonder if going forward, we could have them sent to us at the time that they're posted on the website. Just because it's hard to think back, like a couple of months ago, was there some other discussion that we thought was relevant that should be in the minutes? So I would just ask if we can do that process-wise going forward.
Melissa, I think that's a good suggestion,
Yeah.
right? We should be able to do that.
Yeah, they're always up on the website within 7 days. So once they're posted, I'm happy to just circulate them to the group.
Thank you.
You're welcome.
Any other further questions, clarifications on the November minutes, draft minutes? Seeing none, I think now we can, no, someone's trying to speak.
We have to
Melissa?
ask for abstentions, I think.
Yeah, I need to abstain.
Yeah, I think we stopped before the vote. So I will
Oh,
call
I'm
for
sorry.
a yes, no, and abstain. And we'll try to do it verbally so that we can move on. So since the motion has been moved and seconded, we've had discussion. I'll now ask for the yays and nays. So all those in favor of approving the November meeting minutes, please signal by saying aye.
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 Any nays? Any abstained?
Abstained.
Tricia will be signaled as abstaining. Perfect. The meeting minutes are approved. That brings us to the topic of looking at and reviewing the allocation plan. Again, it's not our intention to force approval, and if folks want to have more time after we walk through it, certainly willing to schedule a special meeting with the sole purpose of being a ratification vote of the board before we formally send it to the legislature. But we did want to take some time for Melissa to share screen the written report and talk through some of the big categories. I'll just make some umbrella comments at the top. One, we clearly tried to reflect the vote that we took previously, which was we're going to affirm the CDC categories and the proportions that they recommend. Obviously, we've adjusted those proportions for the 12 million that we've been allotted to fund. Secondly, based on our conversation, we looked at the statutory charge that we have to look at prioritization in awarding funds based on those categories. And in that case, the board last time had discussed this and felt that the list of priorities was both comprehensive and not wishing to add any for fear of diluting the impact that those core statutory priorities have. We decided to stick with only the minimum required under the statute for prioritization. Next, I'll also say we reflected back on the process that we wanted to move forward with, which will be a DPH-led competitive process. And we put language in there to the effect of making sure to look at other resources so as not to be duplicative. So to the extent possible through the evaluation process and through the scoring process, we'll certainly look at giving extra points and awards for those that are able to leverage federal funding or matching funding. So something like if someone was able to braid together dual funding or existing resources, that would be favorable to their scoring. And we've reflected that as being part of the allocation plan. Finally, per the statutory requirements, we have some flexibility. I know this was of interest to the board. I think Dr. Sellner, you were one that initially flagged this, is that we are putting dollar amounts, and it's a little hard to predict exact dollar amounts. And how do we allow some flexibility? We look back at the statutes, and we are allowed of some flexibility, a $50,000 threshold or a plus minus 10%, whichever is less. So we made that very clear in the allocation plan that per that statutory flexibility, we would ask that the plan as adopted reflect that we have the flexibility to make those adjustments. So with that, I'll turn it over to Melissa, who can walk through. And is your question on the umbrella, or do you want to wait until we talk through section by section? Because Melissa will go through that next.
Yeah, if that's going to be brief, because we do just have 25 minutes left, that I can wait, certainly.
Okay. Go ahead, Melissa. Why don't you screen share and talk through and take any questions?
Great. So Claudia did a really great job framing up the general context and the main focus of the content in the report. So I'll try to keep us brief so we have time for discussion and questions. I would like to thank the previous iteration of the board for their years of allocation plan submissions, because the framework is largely what was adopted here, just an updating and a refresh based on our new charge. So there is a very brief introduction just to set context that there was an initial statute, that the funding was eventually swept and put into the general fund, and due to that, the board stopped meeting. And then a reminder that the board through in 2022, the funds were reallocated and the trust fund board of trustees was reconstituted. And then in 2023, the statute was updated again to refresh the board's charge and focus. And it essentially put the CDC best practices that the board had been using as its guidepost into statute, as well as laying out 4 priority areas for funding. And those are all the things that we went back and reaffirmed in our October and November meetings, that those were the categories that we were comfortable funding and that we didn't want to make any additions or switches. We really wanted to focus our dollars under the 4 priorities listed in statute. For recommended disbursement, just start off with a general reminder that the CDC best practices, what they are, why they're used, that they were historically a guidepost for the board and continue to be a guidepost for funding in moving forward, and just explaining that this was, again, that the CDC best practices have been put into statute and are the required focus of the board for determining its funding allocations. We then get into just a real quick and easy look at the statutory requirements and priority areas for funding decisions that the board had to follow, and noting that these are what we used as our guidepost when we voted on the allocation breakdown at the November 13th meeting. This you have all seen before. It's a slide that we shared at our October and November meetings, and we thought it would be helpful to put here as a quick snapshot for the committees of cognizance as to the statutory charge put before the board when setting allocations. The next part of the report is a deep dive into what our exact disbursement proposal is. So again, explaining a little more about the CDC recommendations, why they are such a good guidepost, and then getting into how this is what we voted on November 13th. We voted on the percentages. The dollar amounts are simply the calculations of the percentages to the nearest whole number. So we took each of the categories, divided them up based on what the board voted on, and these are the dollar amounts when applied to the $12 million. And then again, as Claudio alluded, we make note that we have the right to move between the categories, plus or minus 10% or $50,000, whichever is less. And that if we were to make any greater swings, we recognize here that it would have to go to the committees of cognizance for approval. We also note the traditional that percentages may not be exact due to rounding, like it could be 35.4% or something like that. And then we go on to describe what the funding allocation methodology was. The priority here, this section lists our statutory priority areas, and also our commitment that recommended disbursements from the trust fund are supposed to work in tandem with state funds and shouldn't be in place of state funds. That we're really, our goal here is to braid funding, not to replace one funding stream with another funding stream. And that we are also putting an eye to youth, which we had said in the last meeting when we voted. We said that we wanted to look at youth and young adults and some other items. Then we get into here and it says, using this framework, the board develops specific program strategies and funding levels for each of the following program categories. And this is our justification for why this is the most effective use of the trust fund dollars. And we essentially say that, again, it aligns with CDC recommended programming and funding levels and is in line with all of our statutory requirements, and that we feel good about this because the CDC recommendations are based on scientific research and best practices. It's evidence-based. Our allocation plan allows Connecticut-specific adjustments to the CDC recommendations based on our allotment of funding. We are going to be using a competitive bid process to make sure that we have a transparent distribution of trust funds, and that we will make sure it's a fair and effective approach and for qualified bidders. That by that our plan supports timely conduction of the procurement process and contracting process by effectively and efficiently dispersing funding, because we are supporting DPH and giving them the necessary resources in order to assist us in the very heavy lift of going through the RFP procurement process. We all voted in November to provide some funding in order to maintain the Connecticut Quit Line, which was one of our most successful smoking cessation initiatives. And in both of the retrospective report and the final program evaluation report, Quit Line was highlighted as being one of the most effective programs that we funded, and was strongly suggested we continue funding that should new funds become available. And then we're using this money to coordinate resources across similar tobacco, nicotine, and substance abuse programs and initiatives operated in the state. So again, that braiding of funding, the coordination with DPH initiatives, DEMIS initiatives, making sure there is not unnecessary duplication. And then historically, we just get into here where then I did a deep dive into each of the categories and why we chose to allot, and how we may, since we're new, how the board may decide to use the funding in an RFP process based on the CDC definition for each category. So essentially this section, which breaks down our category to justify it, starts off with how the CDC defines the category, each category. So you'll notice that, and then goes into examples of previous programs and initiatives that were funded by the Tobacco and Health Trust Fund. And in order to, that's just to give the committees of cognizance a flavor for what we could potentially fund through an RFP process. And again, we provide links to the full retrospective reports if they wanted to go back and see a complete listing of all of the projects that were funded and the allocation amounts for those projects. So that is the format that's received all through here. Mass health outreach, how CDC defines it, what the CDC defines as being a successful mass outreach program, and then examples of what was funded in the past. And that's exactly how it goes throughout. The one place that's where there's something a little different is in the cessation category. We break format a bit. We talk about what CDC defines as a successful cessation initiative, but then we get into just deep diving into why the board has recommended that 500,000 be set aside from the pool of 4.7 million for the quit line specifically. And here is where I just took some time to define what the quit line is, what it does, and how, thanks to DPH doing a good presentation on this in November, I was able to say what the funding would be used for the quit line moving forward with this pool of 500,000. And then to give some historical context, just put forward how much the previous iteration of the board had allocated to quit line, and some of the stats based on the last funding stream from 2003 to 2016, how many individuals were served, and the quit rate range that was achieved during that time. And that was able to provide a more updated stat that DPH had provided us in November about how many registered users they currently have for fiscal year 2020. Surveillance and evaluation, again, defining what surveillance and evaluation is, and the reason it is so important that we, how the board had historically used the funding to support a third-party independent evaluation process, and why we need to continue to do that now. Administration, again, just bringing home the need to support DMIS so that we can get the money out the door in the way that it is intended. And then we just wrap it up with the appendix that gives our statutory charge and our membership at the time of the November 13 vote, with an asterisk that we have had a new member add since then. So that is the layout of the full report. It is really meant to serve as just an affirmation of what the board has already voted on, with some explanation for legislators as they're reviewing the allocation plan as to what each of these categories are and what was done with the funding in the past.
Okay, so with that, Anne, you have your hand raised. You have a question?
Yeah, thanks so much. Actually, I think in the interest of time, first of all, I think it's a really clear and concise report. So I thank you for that. And I have some minor things that I will send by email rather than taking up time here. But the major issue that I just wanted to raise is that I don't have any concern about the percentage of funding allocations, but the overall amount that we have there is 12 million. And so my understanding is that the 12 million was deposited last April. And so my guess is that we have, considerable investment or interest, at least on the principal, and we haven't had a report from the treasurer, as far as I recall, is like how much do we actually have in there over and above 12 million, and I wonder if maybe, I mean, it's got to be at least $500,000, I'm assuming. I'm wondering if we can find that out and actually allocate, a bit more to each category based on that, using the same percentage. And I appreciate what you did, that everything is kind of to the $1,000. I don't expect that we need to have, something that's, $4,278.71. I'm not suggesting that, but if there is some additional funding that we could that we have available and we could add, that it might behoove us to do that. So that's what
let me just give some perspective on that. So generally speaking, I think the better approach, because interest will be accruing in real time, and so we'll always be sort of catching our tail. I would prefer us sort of get a report from the treasurer at the end of the year or at the time of the new deposits, and then say it moving forward. So our next tranche will take into account any investment earned that we know for the prior year. This way it's a set amount and we're not just looking at a point in time, because if we did this now, finalized it, transmitted to the General Assembly, it doesn't get approved until March, even that will be off. So there will always be a need for some sort of carry forward. And I wonder if it's just, let's start with the 12 and then let the interest build, get a report from the treasurer when we get the deposit, and then we know our set of dollars for the next tranche.
Sure, I would just ask that going forward, that at the time we vote on recommendations, that we have a report from the treasurer about how much November. But yes, I'm fine doing that once a year, but I would just suggest that we do it closer to, you know, when we're actually voting next time around.
Yep. Okay. Good point. Suchitra.
Thank you, Claudio. I guess I have a kind of a general question, a query, so to speak. Not being very familiar with how these processes move forward. This is funds we got in 2023. So what is the timeline for the next steps, you know, from a legislative perspective? What happens after we vote on this? Where does it go next? And when does this whole RFP process start and the allocation of funds start, you know, for these dollars? We are in 2024 now, so just curious.
Great question. So I'll start and I'll have Melissa check me and Vanessa and add to any response. So the next step here is once we give board approval, we will clean up any sort of technical edits. I think Ann had mentioned she has a few things she wants cleaned up. So once we reconcile and do a proofread of it, we will transmit it to the legislative committees of cognizance, in this case, Public Health and Appropriations. Appropriations and Public Health then have basically a choice. They could either just, you know, read it and let time pass. I believe, Melissa, it's a 30-day period. So they could do nothing for 30 days and it's deemed approved after that 30-day period. Or should they choose to sort of, you know, elevate and have a discussion about the investment plan, the importance of this work, they could hold a public hearing and committee vote. We would then invite the board members and our advocates and stakeholders who have been part of this process to be part of that, submit testimony and talk through it. And then the legislature would then vote within their 30-day period affirmatively to move forward. Once that formal approval happens, then DPH will, I think immediately, right, DC Terra Nova, be able to do the quit line. That's a sole source, it's dedicated and it's called out. So that will be on autopilot and they can move towards contract development. For the other pieces, it will initiate the RFP design committee, drafting up the RFP for each of the categories and establishing an evaluation committee. And so that process, you know, can vary depending on how long and how difficult it is to coordinate all the people that are drafting and getting it through legal review. But certainly it's I don't even want to guess DC Terra Nova because every agency is differently. Are you comfortable putting a limit on it, maybe within 6 months? Is that a fair to get a RFP just out at least?
Yeah, I think so. And I think, you know, staff has been working on a framework at least so that when the group is able to get together, they're not totally starting from scratch. So it shouldn't take, you know, quite as long. But yes, it is a process when we have to involve the legal side of things and some editing on the language. So.
Okay. Does
And
that
I
answer your
just think-
question, or Melissa, anything else?
Oh, I'm sorry, Claudio. Thank you. I just think one piece of helpful context to Chitra might be that although yes, we are well into 2000 or in the beginning of 2024, we don't actually, the state of Connecticut doesn't get the settlement dollars until April 1st. So we're not quite as far behind as it feels like we are. And then once Connecticut gets the dollars, we need the dollars to be then allocated to our moved into the trust fund. So I just was able to confirm. So April 1st is when the deposit comes to the settlement dollars come to the state of Connecticut. So we did get them, but when we checked even before the June 21st meeting, they had not yet put the 12 million set aside for us, but it's reflected now. We work
So this
with.
is from last year though, right? That it's still from,
It's
it was last
April
April.
April 2023. Connecticut received the settlement funds. Yep. And then we're supposed to receive them April 1st of each year.
Yeah. So, the only reason I asked this is not to belabor this point, but we'll be constantly catching up, right?
Yes.
Because every year we're going to have this delay now. So but it's all good. As long as we have the money and it doesn't go anywhere else, that's great.
But the good news is we're formed now. We also weren't a body that was formed. So we'll hopefully be able to move a lot faster when we get the next deposit.
Tony?
Sure. On administration, because I guess how fast everything moves really depends upon that. How is that going to work? Or do we have any idea of how that's going to work? And will there be any board oversight on any of that?
Well, DC Turno, I would turn to you if you have any thoughts, but I think oversight may be a different word than I would choose. I would say there's going to be board engagement and opportunities for board members to have involvement at whatever level they choose. So evaluating and scoring or designing of the RFP would be certainly within the purview of board members' duties and opportunity.
So here's my concern, and it may not be well founded, but as I read the paragraph, it appears as if some of this work has been done by federal funds, and the real question is, will our dollars supplant federal funds, and will they be off doing something else? And that's what I mean by oversight. I don't think we want to know who's going to be hired to do what, but we want to know that our money actually expands what the department can do rather than supplant other things. But then as I heard about how long it's going to take to get everything up and running, if there were to be new staff hired, that would even be a longer period of time. So I was just wondering if we're going to be looking at that.
I can just answer a little bit of that question. So certainly the money can't supplant the federal dollars, and so it wouldn't. When we look at the CDC best practices and the number and types of folks that we should have employed and engaged in this work, we're not quite meeting the best practices. So we would look to use this money to fill in some of those gaps and have new staff working in new areas. Specifically around here would be the contract management piece. So yeah, they wouldn't be hired at this stage to put out the RFPs, but then when those contracts get executed and then we need to follow up with the contractors and get their reports and look at some of those evaluation pieces, we would have new staff on board to be able to do that new work.
And I may have read it incorrectly, but what I understood by reading the administration piece was that they would not be contractors and the evaluation folks would be. So am I wrong in the way that I read that? And honestly, we can talk about this later because it has to go to the General Assembly, but as long as we kind of understand what we've got and how quickly the department as a boots on the ground can implement, I think that's important. And we just need to understand the balance of the way in which things work. And so I know we don't have a lot more time, so I'm not going to belabor this. I just wanted to point that out.
So then the decision is whether the board believes that we want to take an affirmative vote at this point, or we want another week or two to read, digest, give some edits, and then we have a special meeting with one topic being just to sort of vote on this allocation plan. So mindful of, we're going to get into legislative session, and February 7th is the official opening day of the regular session. So it would probably be good that we get it quickly over so that they can act at some point in the lull before they start getting their own substantive bills and public hearings on the budget and such. So I'll take feedback from the board. Do we want to wait a week or so and try to schedule a very brief meeting, or do we feel comfortable voting affirmatively? Dr. Salner.
Thanks, Claudio. I am satisfied, having lived through prior eras of the board's activities. I'm satisfied that the document represents what we had discussed, so I would like to make a motion to approve.
Great. Representative Harrison.
I guess I was going to say I'd like some time to look at it, but I'm okay with what we did flip through, and you know, I'm probably the newer person on the board, so if everyone else is comfortable, I'll be all right.
So I think and maybe you're going to do this for me, which is the motion was made. Can I have a second, and then we can open up to discussion? I think that'll be the better process way. So would you be willing to make that motion? And is that why your hand was up?
Well, actually, I was just I can quickly say what my minor edits were going to be, or can I just make the motion that, you know, we improve it in substance with some minor edits?
I would prefer the latter, which is with conforming changes, so that if we find another small thing, yeah.
Okay. So I will move that.
Okay, so a motion has been moved and seconded to adopt the allocation plan for transmittal with conforming edits changes.
I don't know who seconded it, though.
So since you're making it, Dr. Salner, will you second that motion?
Yes.
Okay, sounds good. Now that it's been moved and seconded, any further discussion? Seeing none, I think, Melissa, for this, I'd like to take a roll call just so we affirmatively have the numbers.
Okay. Let me just pull up the list. Give me 1 second. Okay. Claudio Gualteri.
Yes.
I apologize. Just give me 1 second to get all the members up. Ann Foley.
Yes.
Matthew Jasinski.
Yes.
Suchitra Krishan Sarin.
Yes.
Deputy Commissioner Jody Terranova.
Yes.
Aisha Clark. Oh, Aisha, are you on the phone? Okay. Tony Harp.
Yes.
Parisa Charmchi Goodwin. Oh, are you? I think Parisa might be muted. Matthew Jasinski.
I think you already called me, but yes.
Oh, I'm sorry. I apologize. Andrew Salner.
Yes.
Christopher Moran.
Yes.
Robert Boris.
Yes.
Trisha Orozco.
Yes.
Michael Rell. And Representative Cindy Harrison.
Yes.
Claudio, everyone who voted yes. Everyone present voted yes.
Okay, so the allocation plan is approved for transmittal with conforming changes as needed. We will notify the board as soon as we transmit it and put you on copy so that you're aware. Once we know of any decision by the committees of cognizance on whether they choose to just allow a period of time to lapse and deem it approved, or whether they want to affirmatively hold a public hearing, we will certainly let you all know so that you can be part of that process as you deem fit. So last item for our agenda today is public comment. I know we had some excellent members of the public who bear with us through this process. And so I want to now recognize them for a few minutes if they'd like to make any statements or comments. If not, I will just recognize that Senator Anwar has attended, and it's always important to have both Representative Harris here formally on the committee, but also the Senate Public Health Chair monitor these, since this will eventually come before their committee. So great to see his continued support, as are many of the advocates, including Bright Johnson. So appreciate the well attendance that we had, including at one point, Melissa, today, I think it's a red letter day because we had 100% Tobacco Trust Fund membership. Now, some had to drop off, but it is a good sign that we have members that are engaged and actively show up. So seeing no public comment, the final item is a motion for adjournment. Do I have a motion to adjourn?
Oh, Claudia, may I make one just one process point? I'm sorry, anyone who has edits to the report, if you could just, you can send them directly to me, any of your technical edits at, you have my email because it's on all your Outlook invites. It's on all the emails I send you. And if you could get them to me by next Wednesday, that would be great. I'll make it and we can get this off by February 1st to the legislature. Thanks, Claudia.
Great. So now that leaves the motion to adjourn. Trisha?
Second motion.
Thanks, motion. Do I have a second?
Second.
Second by Christopher. All those in favor of adjournment, signal by saying aye. Aye.
Aye.
Any opposed? Seeing none. Have a good afternoon, everyone. Thank you.
Thank you. You too.
Bye, everyone.
Bye.